Hello everyone, I'm so happy to be here with you guys today. Today I get to talk about something that I talk about in my office all day, every day. It's very near and dear to my heart, maybe a baby. It's a topic on preconception. My name is Dr. Marie Sharpe. I am an OBGYN by training, and I also have a master's degree in genomic medicine, and that's kind of a side hobby for me. I'm an OBGYN at Newport Center Women's Health, and I deliver out of Hoag. I've been in practice in this area for a little over a year, and I'm really excited to talk to you guys tonight. All right, so the whole topic of considering having a pregnancy really comes down to a couple of questions. Do you want to be pregnant, or do you want to start a family soon? If you do, when? And if you're planning to have a pregnancy, do you need to do anything to prepare? So today we're really going to kind of hone in on the preconception part, not as much of the pregnancy part, but I am going to touch a little bit on the initial steps of trying for a pregnancy as well. So one thing to kind of start out with is a statistic. So in the United States, 45% of pregnancies are unintended or unplanned. So there's definitely some room for improvement for us from the OBGYN standpoint. So what is preconception counseling? You've heard me say that a couple of times already. So preconception counseling is basically encompasses all the components that go into making sure that you have a pregnancy when you want to, that your pregnancy is as healthy as possible, and also that your baby is as healthy as possible. So some of the components that go into a preconception visit is going to be talking about your vaccinations and immunizations, health conditions that you have, so past medical history, past surgical history, your family history and genetic history, as well as the medications that you take, the food that you put into your body, infections that you've had in the past or exposure to infections currently or in the future. Substance use, as well as weight and exercise. So I'm going to go into each one of these components in a little bit more detail, but it's a lot of information. So I just want to kind of remind you guys there is a chat box that you can put in some questions, and I'd be happy to answer those at the end. Alrighty, so first we're going to talk about vaccination status and immunizations. And so this really encompasses this whole list of immunizations, which I'm not going to talk about every single one, but I am going to talk about some of the main players that are important for prior to pregnancy and during your pregnancy. So the first one is Tdap. So this is a vaccine that stands for tetanus, diphtheria, and pertussis. Pertussis is whooping cough, which is probably what you know it as. Tetanus or Tdap is recommended for adults every 10 years. We specifically worry about this vaccine or start talking about it when it comes to pregnancy because we want to give this vaccine in your pregnancy so that you'll pass those antibodies to your baby. The reason that we worry about this is that there's an increased risk of complications in little babies that have pertussis. So specifically babies that are less than 6 months of age. They've got an increased risk of having problems like difficulty breathing, pneumonia, they can have weight loss, brain infections, and at the scariest end, death. Infants receive their first vaccination for whooping cough around 2 months of age, so there's a gap there that we like to address with vaccination during your pregnancy. So a couple other vaccinations that are good to get screened for prior to conceiving is going to be varicella, which is chickenpox, and MMR, which is measles, mumps, and rubella. These vaccines are not recommended and actually contraindicated. We can't give them in pregnancy. You generally will get these vaccines in childhood, and then we can confirm by blood testing that you have immunity sufficient against these infections. If you don't have evidence of immunity, then we do recommend vaccination prior to pregnancy. Varivax vaccine, which is for chickenpox, is 2 doses, 4 to 8 weeks apart, completed at least 4 weeks prior to conception. In simpler terms, you'd have to start your vaccine series 2 months prior to starting to conceive. MMR is a little bit simpler, 1 dose, 1 time, just has to be 4 weeks prior to any attempts to conceive. Alrighty, so moving on to the flu vaccine. So the flu vaccine is recommended annually during or just before the flu season. So depending on when you're planning your pregnancy, that may be either before or during pregnancy. The live vaccine is not recommended during pregnancy, but thankfully that's not the usual one that you're going to find. Most of them are an inactivated form of flu vaccine, which is perfectly safe in pregnancy. COVID-19 vaccine. So I know this is a very hot topic, and I'm just going to kind of go over general recommendations for COVID-19 vaccine in pregnancy. So it is recommended in pregnancy by the CDC and the American College of Obstetrics and Gynecology. So that's kind of our governing body that tells us what is the standard of care for our field. So the best vaccines to receive are going to be either Pfizer or Moderna. Johnson & Johnson is good, but it actually has an increased risk of complications like blood clots, especially associated with pregnancy. And so Pfizer or Moderna is superior if you have the opportunity to receive those. We worry about this because unvaccinated women are at increased risk of maternal and perinatal complications. Our preliminary data, which is changing all the time, is showing an increased risk of C-section, stillbirth, which is demise of the baby in the womb, and preterm labor as well. Another question I get asked all the time in my office is the association of these vaccines with infertility. And we now have about 3 years or so of data, and we don't have anything demonstrating that either one of these vaccines or boosters has been linked to infertility in men or women. So this is ACOG, which is, just as a reminder, is our governing body. Their updated recommendations that came out about 3 weeks ago. So we recently had the release of a new booster, which is a bivalent booster, which is different from the previous monovalent. Details aren't super important. They did come out recommending that this vaccine be given to everyone 12 years of age of older, including pregnancy, as long as your last vaccination, either booster or primary series, was 2 months prior. Alrighty, so looking at health conditions and how those may affect your pregnancy. So certain health conditions recommend that we do some pre-work prior to getting pregnant to make sure that your pregnancy goes as smoothly as possible. So these are a few of the conditions that I'm going to go over in brief and kind of talk about how we would counsel prior to pregnancy. So chronic hypertension, which is elevated blood pressure, we define this in pregnancy or during pregnancy as greater than or equal to 140/90. It's a little bit different outside of pregnancy, but we want to know what kind of medications you're taking, as some of those medications can be harmful for your pregnancy, and some of them are just not optimal. We also want to screen for associated conditions. Sometimes people will have issues with their eyes or heart associated with high blood pressure. Ideally, making your blood pressure optimal is going to decrease the risk of having uncontrolled blood pressure in pregnancy or having a poorly grown baby. In other words, a very, very small baby. Alrighty, pregestational diabetes is basically diabetes that was diagnosed prior to pregnancy. There's 2 types in general, type 1 and type 2. This one is really important to have optimized prior to getting pregnant, as blood sugars early on in your pregnancy have been associated with major malformations or birth defects in babies, some of which can be so severe that they're not compatible with life or continuing the pregnancy. Ideally, we want your blood sugars as close to somebody who doesn't have diabetes as possible prior to pregnancy. Again, we want to evaluate for associated conditions, heart issues, eye issues, issues with your vessels, things like that. This, as I mentioned previously, would have an increased risk of having high blood pressure in pregnancy, birth defects, and some growth abnormalities. And that can be either too big of babies because they've seen too much sugar, or too small of babies because they didn't get enough of the nutrients that they needed. All right, so thyroid disorders, these are very, very common. This is either thyroid being too high, so functioning too well, or too low. It's really important that the thyroid is controlled prior to pregnancy as well. Specifically, it's one of the causes of recurrent miscarriage or losing a pregnancy early on. It can also be associated with preterm birth and high blood pressure in pregnancy. So ideally, we want you to speak with your endocrinologist who's been managing your thyroid to make sure that we're on the same page and everything is set prior to attempts to conceive. Mood disorders. So this encompasses anxiety, depression, bipolar, all sorts of mood disorders. And certain disorders we know actually get worse in pregnancy. Some get better, some stay the same. but certain medications are safer than others. And so we have quite a bit of data now on use of different types of medications in pregnancy. And so it's good to have a discussion with your doctor about, which one would be the safest for you to continue on. And ideally, we want this co-managed with your psychiatrist, psychologist, and OBGYN. Alrighty, HIV, or human immunodeficiency virus. The key with this is that we want to try to reduce the risk of transmission to your growing fetus or your growing baby. And to do that, it's ideal to have a viral count that's undetectable. In other words, we can't find the virus in your blood. And that should stay at the case throughout the pregnancy. So continuing your medications that you were on prior to pregnancy, working with your infectious disease specialist, all of that can drastically reduce the chance that your baby will be affected by that condition as well. Okay, history of weight loss surgery. So this kind of includes the whole gamut of weight loss surgeries. So there's lap bands, gastric sleeves, and bypass surgeries as well. Most women will have a period of excessive weight loss over 12 to 24 months after surgery, and this can actually increase your risk or increase your fertility, along with the fact that there's also a poor absorption part of a lot of these types of surgeries, which can decrease the efficacy of your birth control pill, all leading to unintended pregnancies. Ideally, we don't want you to get pregnant after you've had a weight loss surgery within 1 to 2 years, just because of all of the changes in your nutritional deficiencies, potential for you to be malnourished, and how that could potentially affect your child. We're almost done with the health conditions. Bear with me. I know it's a lot of information. So next we're going to talk about thrombophilia, or history of DVT or pulmonary embolism. These are all fancy words to say that you have basically an inherited predisposition or tendency to clot, or you've had a blood clot before in your legs, arms, or heart. So in general, we would recommend blood thinners in your pregnancy and for at least 6 weeks post-delivery, because pregnancy is actually a pro-clotting state. So even people who have no history of blood clots are at risk of blood clots in pregnancy. And then finally, a history of prior complication in a pregnancy before. So in general terms, if you've had a problem before, it is higher likelihood to happen again. And a lot of times there's things that we can do to try to reduce the risk of you having that complication for a second time. So talk to your doctor about ways to reduce that recurrence. One example is preeclampsia, or high blood pressure in pregnancy. We have found over lots and lots of research and studies that giving aspirin in pregnancy can reduce your risk of having a preterm delivery associated with high blood pressure and having high blood pressure at all. Alrighty, so jumping on to medications. So this includes everything that you take. So prescribed medications, over-the-counter medications, and supplements. It's important to know that out of all of the medications that the FDA has approved, less than 10% we think we have enough data to say that they're safe or not in pregnancy. And so ideally, we want to limit any exposure to medications that aren't absolutely necessary, especially in the first trimester. The reason that we have this kind of gap in data for pregnant women is that they're generally excluded from drug trials, of course, because we don't want to cause harm to them or their growing baby. The other interesting one to talk about is partners' use of testosterone. So some partners will use testosterone, and that can actually decrease their sperm count or eliminate sperm altogether, which can increase the risk of infertility issues. So it's important to talk with your doctor prior to starting trying attempts to conceive, to make sure that all of the medications that you're taking are absolutely necessary, especially in that critical first trimester. Alrighty, so family and genetic history. So this is my love of genetics. So we always want to ask about your family history. So does your family have healthy babies in general? Do they have heart defects? Do they have problems with their spine? Cancer syndromes, things like that. So that we can offer targeted testing prior to conception, or we can screen high-risk ethnic groups. So we know that certain groups of people are at higher risks for certain types of conditions, and we can offer them targeted screening. Everyone is recommended to undergo screening for cystic fibrosis and spinal muscular atrophy, just because they're so prevalent in the population. And ideally, we want to do this prior to conception, because then we have the ability to actually make a meaningful change and reduce the risk of you passing that on to your baby. So most of the conditions that we screen for prior to pregnancy are going to be inherited in what's called an autosomal recessive pattern. It's a big word. All it really means is that you need to have a bad copy from both mom and then a bad copy from dad. So I'm going to give you a little question here. So a patient undergoes routine carrier screening and is positive for a single mutation for cystic fibrosis. The father of the baby is also positive. What is the chance that their child will have cystic fibrosis? So looking at this graph here, the big C is going to be normal, the little c is going to be abnormal. So if you look at the chance of inheriting two small c's, it's 25% chance. So in other words, if you test positive, your partner tests positive, your child would have a 25% chance of being affected by these types of conditions. Nutritional optimization. So really the key is balance, okay? So we want you to take in all of your major macronutrients, so, proteins, carbs, fats, as well as, your micronutrients as well, calcium, folate, iron, vitamin D. We ideally want you to start a prenatal vitamin 1 to 3 months prior to your attempts to conceive, because that's actually the most critical time to increase all of your nutritional stores, because they're going to be used the most in that first trimester, which happens to also be the time that most women don't necessarily feel like eating the most balanced of diets. For supplementation of folic acid, we recommend at least 400 micrograms a day if you don't have risk factors otherwise. If you do, and these risk factors could be diabetes, could be a history of a child with a spine issue or a family history of a child with a spine or brain issue, or certain types of medications used to treat seizures, would decrease your folic acid and would require that you take more. And like I said, balance is key. No fad diets, nothing like that is going to be good preconception or in pregnancy. We really want to avoid restriction, specifically low carbohydrate diets like keto diets and things like that. So one of the new hot micronutrients in research lately is choline. So choline is critical in the development of the fetal brain. So this is important for having your baby's brain develop and actually making it resilient to certain insults and things that it goes through in the womb and after delivery. Ideally, we want you to take in 450 milligrams a day. Most prenatal vitamins have between 10 to 50. So that leaves a really big amount that is ideally obtained from your diet. This is generally found in eggs, meat products, seafood, dairy, animal type byproducts, okay? And it's ideal. I tell a lot of my pregnant patients, have a couple eggs a day. That's gonna get you very, very close to your requirements daily. If you are a vegetarian or a vegan, it's not really possible to get everything that you need from diet alone, and so oftentimes we'll use supplementation. All right, weight recommendations. So the biggest take home here is normal. We want your BMI to be normal, which BMI is body mass index, which is a measurement or a calculation that takes into account your height and your weight. It then calculates a number, and you see on this chart, which is very busy, the green area is going to be normal. So that's a number anywhere from 18 to 24.9, and that's going to be ideal to be prior to conception. Underweight has risks, and so does overweight, or obese also has risks. So exercise recommendation. Regular aerobic exercise is recommended before, during, and after pregnancy. This is a very common question that I get in the office. We want you to get your heart rate up. We want you to do the things that make you feel good. The goal is at least 150 minutes of exercise per week. That can be broken up in any way. You can do 30 minutes a day, or you can work out longer for fewer days. The general rule of thumb is if you did it prior to pregnancy, you can continue through. So I always joke, now is not the time to become a marathon runner or to take on being a power lifter, but if you did those things before, you can often continue them in pregnancy with some degree of restrictions, especially the farther along you get. Alrighty, infectious disease prevention and screening. So most of these types of infections are screened for at your routine annual visits with your gynecologist, but we also screen for them in the first trimester of pregnancy. They include things like gonorrhea, chlamydia, HIV, syphilis, and hepatitis C. We worry about these infections because they can all cause problems in pregnancy. So I have pictured here some condoms. That's the number one way to prevent obtaining any of these infections. So I have to just do my little plug for that as well. Another infection that I get asked about frequently is Zika. So Zika is an infection that's transmitted by mosquitoes. It used to be transmitted in the United States and it hasn't been for quite some time now, but it is transmitted in areas around us like Mexico. And so the biggest or the best thing to do would be to prevent from ever getting an infection. And the ways to do that is to reduce the risk of getting a mosquito bite. So by wearing long sleeves, long pants, staying away from standing water, bug repellent, peppermint oil, all of those types of things can reduce your risk of getting a mosquito bite. If you do get exposed or infected with Zika, it actually stays in your either your eggs or the sperm. And so we recommend 2 to 3 months of waiting prior to attempts to conceive. Substance use. So alcohol is a big one that I talk about a lot. At this time, no safe amount is recommended in pregnancy. So what we worry about is a syndrome called fetal alcohol spectrum disorder, which can really vary from being very mild to being very severe. But we, at this point, do not have data to say that this much is safe, this much causes fetal alcohol syndrome, and so it's best to abstain entirely. Tobacco and nicotine use, highly recommended to quit prior to pregnancy. There is a significantly increased risk of complications like preterm birth, having your water break early, placental abnormalities, and even persisting into childhood. These babies have more problems with asthma, obesity, and can have colic or GI issues as well. Marijuana use, I know you're able to use it now legally, but we don't recommend it in pregnancy. It does not appear to be safe. A lot of patients will use it in the first trimester to help with their nausea and vomiting, but there is actually a paradoxical or an opposite reaction where it can make your nausea and vomiting worse in pregnancy. We also worry about the effects on the baby's brain and development from like an intellectual point in childhood as well. Prescription drug use or abuse as well. So these are things like narcotics and benzodiazepines. Narcotics are things like Vicodin, hydrocodone, Dilaudid. Benzodiazepines are mostly your anxiety medications like Xanax, lorazepam, Ativan, things like that. It's really important to speak with your doctor on a case-by-case basis of which medications you're taking, why, and if there's a way to get you off of them prior to pregnancy or in a smaller dosage. All right, so it's a lot of information, and now we're gonna kind of briefly go through my health is optimal. What do I do now? So pregnancy planning, the things that kind of go into that are gonna be age, menstrual cycle, your periods, time between your pregnancies, if you've had a prior one, and do you need to be seen by an OBGYN or do you need to be seen by a specialist? So I'm sorry, ladies, maternal age does matter quite a bit more than paternal age. And what we consider to be advanced or elevated risk would be an age of 35 or above. The reason for this really comes down to the science of our eggs. So we are born with all of the eggs that we will ever have, and then over our lifetime, those eggs will slowly age and decrease in quality. And so that tends to lead to increased complication rates the longer we wait to conceive. So we think fertility starts to kind of more precipitously or rapidly decline in the early to mid-30s. What we specifically worry about is the risk of aneuploidy, which is an abnormality of the chromosomes. Specific example of this would be Down syndrome, where a baby will have an extra of chromosome 21. You also have an increased risk of pregnancy loss, can be up to 40 to 60% for women trying to conceive in their early 40s. Ectopic pregnancy, birth defects, and then once you're pregnant, an increased risk of diabetes, high blood pressure, and problems with the placenta. But I want to include men in this too. So paternal age also plays a role. We don't have as much of a consensus on advanced paternal age, but we think 40 is probably a good number. They do have an increased risk of conditions that are autosomal, which means just one bad copy causes a disease. So these are things like Marfan's, achondroplasia, or dwarfism. You also have an increased risk of abnormalities of the chromosomes and miscarriage, but not to the same degree as we see with maternal age. So the key things to ask yourself before you try to conceive is, what is ovulation and am I doing it? So this is an ovary here. So ovulation is the release of a dominant follicle or an egg from your ovary that occurs once per month. Ovulation has to occur for you to have the opportunity to conceive. One thing to note as well is that as we age as women, this process tends to happen a little bit faster, and our body will occasionally ovulate more than one egg per month. So you see a slightly increased risk of twins as we age. So the next question to ask is, am I ovulating? So this is a chart that's very, very near and dear to most OBGYNs' hearts. The biggest thing to look at is going to be all of the kind of hormonal fluctuations, which I'll hone in a little bit more on. So the best way to tell if you're ovulating or not is, are your cycles regular? Regular means every 25 to 35 days with month-to-month cycle variance of 2 to 3 days or less. So what that means is that your cycles are more or less occurring within 2 to 3 days of each other every month. So if it's 28, 29, 30, most likely you're ovulating. If it's 28, 30, 35, potentially not. There are apps used to predict ovulation, which calculate your fertility window and can tell you the best time that potentially to attempt to conceive. There's also urine kits and blood kits that look at specifically the hormone on the chart here, LH, which surges or increases right before, about 12 to 36 hours prior to ovulation. The best time to conceive is 3 to 4 days before you ovulate, and then continuing 1 to 2 days after. The reason for this is that eggs are fragile. They only last for 12 to 24 hours and then they degrade. Sperm is good for 4 to 5 days, and so the more sperm that accumulates there, once the egg is released, the higher chance you have of conceiving. So interpregnancy interval. So this is a fancy word of saying the time frame from one delivery to your next pregnancy. Ideally, we want this to be about 18 months and definitely less than 6 months, or definitely not less than 6 months, excuse me. So less than 6 months is going to put you at increased risk of complications, which I'll go over in just a minute. Ideally, we want about 18 months. Some exceptions to that are going to be for women who are older or who are undergoing reproductive assistance, so IVF and things like that. Oftentimes, we'll make that interval a little bit shorter to try to optimize other risk factors. So risks of having a pregnancy that's back-to-back includes a slightly increased risk of preterm labor, and if you've had a prior C-section in the past, it increases the risk of that C-section scar opening if you were to try for a vaginal delivery with your next birth. This risk only plays if you've had a C-section in the past. So what if something's wrong? So initial infertility workup can often be initiated by your OBGYN, but there are specialists. So reproductive endocrinologists and infertility specialists are called REIs. All right, they are a subspecialist of OBGYNs, which means that they did an additional 3 years of training beyond my years of training. Their specialty is just the treatment, the diagnosis of infertility. And they work to help you with ovulation, they work with intrauterine insemination, and they also work with in vitro fertilization. When do I need to see a specialist? So the diagnosis of infertility is pretty clear. However, there are times where we will start the workup a little bit sooner than these definitions. So in general, if you are less than 35, having regular unprotected intercourse for 12 months with no positive pregnancy test, or being between 35 and 39, having regular unprotected intercourse for 6 months. So we recommend seeking out the treatment from a specialist if you do meet that criteria for infertility. If you're 40 years of age or older and starting to try for the first time, if you or your partner has a condition that you know will increase the complication rate in your pregnancy, or you're hoping to try to screen for that prior to continuation of a pregnancy, or if you've seen your OBGYN and you have not been able to get pregnant and it's time to get a little bit more of an in-depth evaluation. All right, so your pregnancy test is positive. What now? This is always a very, very exciting time for patients. The biggest thing is call your doctor's office, okay? Establishing care in the first trimester is really, really important for a couple of reasons. We want to confirm that the pregnancy is viable, which means it's in the uterus where it's supposed to be and not outside somewhere in the fallopian tubes or somewhere where it won't be able to continue. We also want to make sure that your due date is correct. So the best way to calculate your due date is to go based on your first day of your last menstrual period and then confirm with the ultrasound in the first trimester. Ideally, we want you to be seen by an OBGYN or at least supervised by an OBGYN, whether you're seeing a mid-level provider like a midwife or a nurse practitioner. It's just important to have an OBGYN available if need be. So how to get started? Just a little checklist of things to kind of work towards in this process. So start taking your prenatal vitamin, make an appointment with your OBGYN, complete your labs to see if you need any vaccinations and then obtain those appropriate vaccinations. Review your family history and complete any recommended genetic or carrier screening. And then start monitoring your cycles using a period tracking app or using an ovulation test kit as well. Next step is to start trying. And good luck. So here's some resources of where I got my information for my lecture. This is me with a couple of my babies here. And then just a reminder that you can follow us on Instagram and also a link to our website as well. Okay. So I have some questions here. The first one is, can hormonal birth control methods impact the chances of my partner and I getting pregnant in the future? Also, what can my partner male do to keep healthy for when we're ready to get pregnant? That's a good question. So no, none of the hormonal birth control methods that we prescribe on a regular basis have been shown to cause infertility or any issues with getting pregnant in the future. What I will say is that there are some birth control methods that you need to stop longer before you attempt to conceive. So what that means is that some birth controls like an IUD or an Nexplanon, you can remove those and you can get pregnant the next month. Other types of birth control, sometimes birth control pills and the shot, like Depo-Provera shot, can take longer for your fertility to resume. And as far as partner, the biggest thing for your partner to stay healthy is if he has any chronic medical conditions, to have them controlled as well. So we talked about high blood pressure and diabetes for women. They can also affect male fertility as well. So having good control of his health, exercising, diet, all of those things can play into helping him increase his chances of being able to conceive or help you conceive. All right. What is the recommended form of birth control until you're ready to get pregnant? That's a really good question too. We don't have one that is absolutely recommended in the sense that it's better than others. Really, any type of birth control is going to be safe and is not going to increase your risk of having problems like miscarriage or complications in your pregnancy. It depends more on the timing of when you want to get pregnant. So if you're thinking you want to get pregnant in 6 months, a birth control pill might be better for you. If you're thinking you don't want to get pregnant for 10 years, an IUD might be better for you. But that's really a conversation to have specifically with what your goals are so that we can help you to achieve that. Do you recommend undergoing any fertility tests? So this is a question near and dear to me. Just because this is something I've looked into quite a bit. I do not recommend undergoing any fertility testing right off the bat. However, I think that comes more into play when you're thinking about delaying pregnancy potentially past 35. So for most of my patients that are under the age of 35 have never attempted to conceive, I don't do routine fertility testing prior to their attempts to conceive. For my patients that are, 34, 33, thinking that they want to start a family, but maybe in 4 to 5 years, potentially I will get something called an anti-Müllerian hormone, or an AMH level, to see about how many eggs they have. The big limitation of this test is that it looks at egg number, not quality. And quality is what actually leads to a successful pregnancy. So it's something that, if you're thinking about delaying fertility past 35 or so, it may be a good idea, especially if you're considering doing something like egg freezing. Okay, will my previous miscarriage affect my chances of conception? The short answer is no. So it depends on what the setting was or what happened exactly with your miscarriage, but about 25% of pregnancies will miscarry, and that number frequently is a little bit higher than you would think, because some of them are pregnancies you didn't even know were there. But for most women who've had 1, 2, even 3 miscarriages, they still overwhelmingly have the odds of going on to have a very safe and healthy pregnancy. The only caveat to this is if the reason for a miscarriage is something genetic, which generally we don't recommend going into like a in-depth evaluation until you've had 2 to 3 miscarriages in a row, at which point we look to see, is there something wrong? Is your thyroid wrong? Is there something wrong with your genetics? Are your blood sugars high? Something like that. How long is realistic for your cycle to return regularly after getting off of birth control pills? So most people's cycle will return within about a month of stopping their birth control pills. That doesn't mean you're ovulating though. So birth control pills work by suppressing your ovulation. And so the longer that you're on them, the increased chance that it may take a few months. It could take up to 3 to 6 months for you to start ovulating after stopping a birth control pill. So that's one that I tend to speak with patients about if they are wanting to stop their contraception and then immediately try, because a birth control pill might not be my favorite thing in that situation. Alrighty, perfect. Well, thank you so much for listening and for all of your good questions. I hope to see you guys in the future. And if you have any questions or anything like that, please feel free to DM me either at Newport Center Women's Health or my personal Instagram, which is a work in progress, but there is going to be more content coming on that as well.